Okay.
And there we go. And damn you. There we go. Can you see it now?
Yep. I see it.
Fuck. Stop running this. Damn this thing. Stop. This. Okay. Okay, can you see what I've got going on now? Is it moving for you?
Yes.
You still with me, Ashley?
Yeah.
Hello? Ashley, still there?
Yeah, can you hear me?
I can't hear you. Can you hear me? What just happened?
Sounds really bad.
Hello?
Hello? Can you hear me now?
You still there, Ashley?
Yes.
Sorry about that. I don't know what's. I'm having a problem. Okay, forget it. It's not going to work, so I'm just going to move on with my life. Okay, so you can see the slide deck.
Yeah.
So we're going to skip all the benign stuff. Skip all the ice. Here we go. So let's get into the definitions. So the definitions. So hypoxia. I'm on the one. So if you move down the slide deck, basically we're on page 1 of the notes themselves. If you're looking at the notes, we're going through the definitions at the very top. So hypoxia and ischemia. Do you know what hypoxia and ischemia is?
Yes.
What's hypoxia and ischemia?
Hypoxia isn't CO2, it's lack of oxygen to the blood flow, right?
So yeah, so it's just deprivation of oxygen in the blood. So there's just no blood, there's no oxygen in the blood itself. And there can be a couple of different reasons for that. You know, like there can be like iron deficiency, that kind of stuff.
Mm-hmm.
So so there's just a lot of different reasons, but basically anytime you hear that term, it just means we're missing iron in the blood.
Okay.
I mean, we're missing oxygen in the blood, and there's a lot of different reasons that can happen. Okay, done. Okay, so that's what's going on there. There's Adriana's with us now. Okay, ischemia. What's ischemia mean?
For me?
Anybody?
Okay. Ischemia is localized lack of oxygen due to blockage in blood flow.
So yeah, so basically, what's the classic example in our neurological section where we talk about ischemia? What's the classic example of this? So stroke is a classic example. So whether that's hemorrhagic or it's blood clotting or embolus or thrombus, anytime you get a blockage in a blood vessel and blood cannot move past that blockage, okay. So levels of consciousness is the next piece. So alert, oriented, confused, lethargy, augmentation, super, and coma. Those are from highest to lowest. So alert and oriented just means, hey man, they're totally with you. They're alerted to place, time, and location. What does confused mean? So confused, what's confused mean?
Confused means that they don't know one of those three.
Yeah, it's things. 1 to 2 of those things. So in alert and aware, they're 3 by 3, totally aware, and confused if they could be 2 by 3 or 1 by 3. They still know their name, but they get confused about the time and location is a good example. So that now they're confused and they're starting to move down that scale of alertness. Okay,
Right.
lethargy. What does lethargy mean?
They're slower to respond. They're still conscious, and they might know who they are and where they are, but they're starting to slur their speech. Just slow movements.
So just generalized slowing. They're just slowing down. They're not quite as fast. They're still alert. They're still alert and oriented, but again, their response time is quite a bit lower than what you would think it's appropriate. Okay, obdentation.
Feel free to stop me anytime because I don't want to be taking for everybody. But obdentation is when somebody needs constant what's the word? Stimuli.
Yeah, prompting.
Get them to respond.
Stay awake, right?
Yeah, you have to either tap their shoulder, move them to get them to respond.
This is what I call poking the kid. You need to poke them, right? You need to poke them to keep them engaged. You just poke them. Okay, stupor. Stupor, anybody? Tanner, stupor?
Stupor. Shoot. I can't remember. Oh, okay. No, okay. So this is. So coma would be zero responsiveness or something. Stupor would be. Shoot.
They vocalize their pain, and they have decreased movement. So localizing pain, I hurt, but they don't want to move.
Maybe somebody who's not responding, not really talking to you or saying anything, but he's moaning.
Yeah, so someone laying on the side of the road who's been struck by a car, they'll lay on the side of the road and they'll moan and scream, but they will not want to move. That's stupor. Okay, finally, coma. Coma is the easy one. No. Coma's the easy one.
Yep.
Does not respond appropriately to stimuli. No verbal response.
Coma means they're asleep. Totally, you can't rouse them. They're totally asleep. That's coma. Okay, moving along. Moving on. Damn. Okay. Son of a gun. Okay, moving along. Next slide is more stuff. Cerebral death and brain death. So, Ashley, do you know what cerebral death is?
No, because they both sound like the same thing to me.
Okay, they are subtly different, and the difference is cerebral death is there's still brain activity. So, for example, if two people, you put them both on a ventilator, they need to be ventilated to be able to see or to breathe. The person who's in brain death, you unplug them, they die. They stop breathing. There's no brain function at all. And cerebral death means that there's still lower level brain function. The brainstem may still be intact. You unplug them, they continue to breathe, and their heart continues to beat on its own.
Okay.
That's the difference. So cerebral death just means that their higher level brain functions are gone, but they still can breathe on their own. And then brain death means they are dead. If you unplug them from ventilation, they stop breathing and they die.
Yeah, that makes sense.
That's the difference. So
the way I like to remember it is that in cerebral death, you still have the autonomic functions. So your respiratory drive, your heart rate, all that stuff is still working. Just the autonomic functions. And in brain death, there's no more function.
Right.
Yes, that's correct.
In order to survive. So yeah.
Okay, so that's that one. So cognition. What's cognition mean?
It's full function of your brain capacities, your skills. You understand, you can express yourself, you can do calculations, This full cognitive means you have all of your capacities.
Well, let me ask a question. Let me ask a question about this. So, would we expect a 5-year-old child to have the same cognition as an adult?
No.
No, we don't. We do not expect a child to have the same level of cognition as an adult. Okay, and so that's what cognition means. It's developmentally appropriate for a child that's 5 years old to not be able to do calculus, for example, or to understand higher levels of anatomy, like those of us in this class have previously studied. We wouldn't expect a child to be able to do that, but there are developmentally appropriate levels for that child that are cognitively appropriate. And so cognition means to be cognitively aware that's appropriate for your age and development. So we wouldn't.
Hello, Christopher?
I think Christopher is muted. Christopher, did you mute yourself?
I don't know why I would mute myself. There, am I back?
Okay, yeah. We
So
didn't hear you for a few seconds there.
So cognition just means that for that thing, whether it's a dog or a human, the response neurally is cognitively appropriate. Okay? A dog doesn't have the same level of cognition as a human, but it is appropriate for what a dog knows. Okay? So dementia, what's dementia? Dementia is really interesting because it goes really, really well with Alzheimer's.
Well, there's deterioration in the structures of the brain, and you start to lose some of your abilities, your cognitive abilities.
So the key things about dementia are it is degenerative, like it's degenerative loss of neural function, and it's irreversible. We cannot do anything to intervene and reverse it.
Correct.
So it's progressive over time, it's irreversible, and it's organic cognitive degradation over time. And it's not reversible. Okay? Delirium. What's going on with delirium? What's going on with what's the key things with delirium?
It's reversible.
Yeah.
Yeah. Yep. It's the delirium is delirium. I see unicorns in my front yard. Are they really there? No, they're not really there, but I may really think that they're there. And so I'm delirious. I have this delirious state. And I may articulate that. That's delirium. It's not true, but to the person experiencing it, it feels true to them.
Sure. It's like being on drugs.
Yeah. Oh, I'm sorry. I was talking about delusion. Sorry, guys. I was talking about delusion, not delirium. Delusion is a false belief brought about without appropriate external stimulus and is unrelated to reality. So again, like people who are schizophrenic, they hear voices. They're real to them, even though you and I would say they're not real. That's delusion. Then delirium, what's delirium?
Delirium is the one that is reversible and has hallucinations attached to it, isn't it?
Yep. So it's an acute reversible. It's an acute reversible state of agitation or confusion. And yes, they're disoriented at time and place with hallucinations. So they see and hear things that are inappropriate. Okay, and it can be caused by fevers.
I want to draw on my painting.
Okay, let's keep going. Okay, moving along to the next slide. Okay, Glasgow Coma Scale. So we hit this again. So now I'm going to just move on. Everybody here has kind of seen this before. What are the 5 levels of consciousness for a patient? So what scale is used to measure levels of consciousness in the patient? What are those 5 things? Trauma.
Oh.
We use the Glasgow Coma Scale to assess trauma, levels of neural impact because of trauma. What are some of the other ones?
Hypoxia.
Hypoxia is one that there would be diminished neural function, and we'd use Glasgow Coma to figure that out. I'm not sorry, guys. My screen sharing is just not freaking working. So I'm sorry.
You're good, man.
Are you guys back? Hold on. I think you're with me again.
So hypoxia.
There it is.
Metabolic disorders.
Infection could cause this.
Yeah.
Trauma. and then vascular injuries. Those are the things that would cause this. Now, under metabolic disorders, there are 4 major metabolic disorders that we're gonna use Glasgow coma to help us assess. Does anybody remember any of them?
Of the metabolic disorder?
Yeah.
Yeah, that's the renal failure,
Yep.
Liver failure. We have a hyperglycemia and diabetic ketoacidosis.
So it's hypoglycemia.
Hypoglycemia, not hyper. Sorry.
Ketoacidosis is hyperglycemia.
That's right.
DKA and HHS are both hyperglycemia disorders. And then hypoglycemia is the other end of that. So whenever I see DKA or HHS, I say hyperglycemia with DKA. Does that make sense? That way it reminds me that it's hyperglycemia that's causing them to be in ketoacidosis or HHS. I appropriately tag those to the appropriate side of diabetes and to hyperglycemia. That always drives me to that. And that's why I always tag them with, I've got DKA, which is hyperglycemia. Yep. Okay. So that's what's going on with those. So we're moving along to the next slide. So those are the 5 levels that 5 things that we assess with. And under metabolic disorders, we assess for 4 specific diseases or areas under metabolic disorders: renal, kidney, hypoglycemia, and hyperglycemia, specifically dealing with DKA.
Awesome.
Okay, moving along.
I think you said renal, kidney.
I'm sorry, renal, liver, hypo,
right.
and hyperglycemia.
Right.
Okay, so who can tell me? Let's go through. I'm going to move us forward on the slides again. Give me a second. So who can tell me what the 3 major areas of, who can tell me what the 3 major areas of Glasgow coma scale are?
Yep. Eyes.
Eyes.
Ooh.
Sorry. Eyes.
Verbal
Eyes,
response.
verbal, and motor.
Yeah.
Okay, so eyes has how many categories?
3.
It's 4.
4.
4. Verbal has how many?
5.
5.
And motor has how many?
6.
Awesome. Okay, so that's that. So, and the total score that you can get, if you are perfect scores, what's the highest score you can get?
3.
That's the
Highest
lowest
is
score.
15.
15 to 3 is the range of Glasgow coma.
Oh, right. Yeah.
You're okay. No, you're okay. Let's go through eyes. So number 4 on eyes, what would that be? Number 4 is
Something with an A that means it can do it, no problem.
spontaneous. They open their eyys and they track objects and they follow targets spontaneously. So it's totally appropriate. Was someone commenting? I'm sorry. I heard someone commenting.
No, you're good.
Okay. Moving on. So what's number 3? Does anybody know number 3? For eyes?
Response to voice.
Yep. They will track to a voice. So they will look at you and track to you with your voice. Okay. But the rest of the world around them, they don't track that. They're confused. But when you talk to them, they will turn and look at you. Okay. To pain.
Yeah.
So their eyes are closed. They're kind of looking like they're sleeping, and you touch them where they have a broken arm. What are they going to do?
Open their eyes.
They're going to open their eyes, and they're going to be pissed. Okay?
Another thing they do is, like, if there's no visible injury and the person is out of it, they press on the nail bed like that.
Yep.
And they sometimes use a pen, put pressure on it, and it hurts quite a bit, and they'll open their eyes if they're still.
There are a couple of different protocols that are appropriate to checking for pain response. And yeah, that's the one they currently teach is the nail bed thing. Some agencies do, they pinch their earlobe. They pinch below on their earlobe, and that will wake people up too.
Mm-hmm.
Or there's a trapezius pinch. Those are the 3 that I know the best. I learned 10 years ago to do sternal rub, where you rub their sternum, their clap, their sternal bone
With the knuckles, right?
Yeah, well, your knuckles, you just rub it into it, and it hurts.
Into their sternum?
What was that?
Into their sternum?
Yeah, into their chest and their breastbone. It hurts. It's not comfortable to do it, but it will wake them up.
Oh, wow.
If they're playing, it'll wake them up.
What's the previous pin?
So verbal component. So what's number 5 on verbal component?
I need to bring my notes. I left them in my office.
That's fine. You shouldn't need it for this. Verbal.
Oriented.
They're oriented. They look at you. They respond appropriately. They use appropriate words, and they complete sentences appropriately. They can tell you about their condition, and they're totally oriented. Okay. What's the next one?
Confused.
Confused. What would confusion mean?
They might not respond appropriately. Like
Verbal,
you
yeah.
Well, we learned before that alert and aware is 3 by 3, right?
Right.
So under Glasgow Coma, we could say confused is they're still talking to you, but they don't know where they're at. They don't know what their name is. They don't know what the president of the United States is. They don't know what time it is. So one of those could be deficient and inappropriate, but the other ones are appropriate. They're starting to be confused about what's going on.
Right.
Okay, they're not totally out of it, but they're definitely in some distress. Okay, number 3.
And this one is the inappropriate words.
Yeah, the word salad. They don't choose an appropriate verbal response to your questions. Okay, the next one. What's the last one? Number 2.
It's the one that's like gibberish.
Yeah,
Yeah.
they're just grunting or they're crying. Crying's a good one for verbal. If they will just cry and that's it, that's inappropriate sound. They're just crying, and they won't talk to you. Okay,
Right.
and the last one, number 1.
None.
None. That's all of them, right? Okay. Then motor. What's the first one for motor?
Okay.
Follows commands, right?
They hear your voice. They hear what you're telling them to do, and they will try to comply with what you tell them to do.
Like you can tell them, like, move your toes.
Yeah, and they do it.
Yeah, they'll move their toes if they have the capacity to, obviously.
If they can do it, they will try to do it. Or if you say, my favorite one is in a mass casualty situation, right? When there's multiple people have been hurt, like an explosion, you holler out to the group and say, if you can hear my voice and you understand me, stand up and walk towards me. If they're able to stand up and walk towards you, their neural's intact and they can walk. Okay? It makes it easier to triage people. Anybody who can do that is low priority.
Right.
And that's a way to assess like 20 people really fast. So they'll follow your commands. Okay, everybody else is hurt. Their legs are broken, whatever. They're not breathing right. They're in heart attack, cardiac arrest, or whatever. They're trapped under a building. They're trapped under rubble. They won't be able to get up and walk towards you. You got to deal with them differently. Okay, what's number 5? They localize their own pain.
Yeah, localizes pain.
This is what I like to call guarding. They'll pull if their arm's broken. They will pull their arm in and they will protect it towards their body. That's called localizing their pain. You know their arm is hurt when they do that. Someone who's choking will grab their throat. Right? They'll localize their own pain for you.
Right.
Okay. What's number 4?
At the
Withdraws from pain.
Yeah, they withdraw from pain. So if you antagonize an injury or something going on with them, they will pull away from it. They respond to it. Okay, the next 2 have to do with decorticate and decerebrate. Decorticate and decerebrate. The next 2, they have a different name for them in Glasgow Coma, but they're regards to those two words.
The 3 is the equivalent of the corticate, right? Where they kind of bend into the abdomen, kind of.
Like, they'll go into the sit-up position and they'll pull their torso towards their knees. Okay. What's abdominal extension number 2? What is that associated to?
The decerebrate.
Decerebrate, yeah.
So they flex back, head back, and back will be arched up. Clearly, for someone who's in pain, that's weird looking. That doesn't look right, does it?
Right.
It'll look really weird if you ever get to see it. I mean, it's obvious there. It's not right. You're like, what the hell is going on? And then the number 1 is none. So that's what those are.
Yeah.
Okay, moving right along. Okay, we're gonna pass the review questions. Okay. So let's get into the different posturing. Decorticate and decerebrate. Okay, Okay, there's a couple of quick things with decorticate and decerebrate we want to make sure we cover. We covered what they are and kind of how they present, but let's talk about why they present the way that they do. So pathologic posturing for decorticate is damn it, I'm using the wrong mouse. Okay, we're on the same page. Good. So hold on. Present to everyone. Okay, now we're on the same page again. So decorticate is damage may be in the cerebral hemispheres and possibly the midbrain. That's where the damage that's causing that posturing is at. So it's in the cerebrum, it's in one of the hemispheres or both hemispheres, and then it's down in the midbrain. Where is decerebrate at? Tanner.
If decorticate's in the cerebral hemispheres, is decerebrate in the cerebellum?
Yeah, so basically it's more severe damage, and it's possibly it's down further in the midbrain. So if we covered the cerebrum and we covered the midbrain, then the only place left for us to go to have damage is down in lower in the brainstem from there.
Okay.
Because decorticate's going to be what's presenting higher up, and as you move down, you get to those lower level centers in the midbrain. And in the brainstem, excuse me, and that's decerebrate. When you have those injuries, you get decerebrate action, hands pointing away from the brain, hands pointing away from the body. And then finally, what's flaccid paralysis?
They are not moving at all, and they're floppy, like a rag doll.
Yeah.
They're just limp. It's just dead weight. Okay, awesome. Moving along. Okay, we're on slide number 21. Okay, actually, we're going to go to 22. We're not going to review. We're going to go right into, okay, recognizing a neurologic event, or basically recognizing a stroke. It's the acronym FAST. So who knows what the acronym FAST stands for in detecting stroke? So F.
Face.
Yep,
arms.
Face. Arms,
strength, and time.
Speech and time.
Speech and time, sorry.
So what about the face? What do we need to know about the face?
We want to make sure that it's even, like there's no flaccidity on one side.
Yep, any drooping, no drooping.
Yeah, ask them to smile and look and see if their smile is pretty even, because not everybody smiles completely evenly, but if one side is completely down while the other side turns into a smile, then you know there's that.
There's neurologic dysfunction, right?
Yeah, paralysis of one side of the brain.
Yep, that's what's going on. Okay. So what about arms? What's going to happen with the arms?
So if you're trying to raise both arms at the same time, one arm won't be able to raise as high, and say it's your right arm. Then that means it's the left side of your brain that's being affected.
Yes, that is true. That's totally right on target. Okay, time. What was important about the time?
You missed the speech.
Oh, I'm sorry. Speech.
Speech. Will it be slurred or just kind of like gibberish?
Yes. That's it. It's going to be slurred and gibberish. And hey, if half my face has gone to sleep, right, from face, is that going to affect my speech?
Oh yeah.
It's
not going to sound like.
There English. You go. It's pretty dang obvious, right? And then time. I'm sorry, we're moving on to time. So what's going on? What's important about time?
We have to.
Yeah, we have 3 hours to treat them. But what are we concerned about in that 3 hours? If we're going to treat them with something in 3 hours, what do we have to know?
Well, first we have to figure out what type of problem they have, whether it's a hemorrhage or an embolism. And those 3 hours is the period of time where we can actually give them a clot buster.
When are we not going to give a clot buster?
If you're hemorrhaging. If it's a hemorrhage, you do not give them.
Yep, we want to be clear it's a hemorrhage, and then if we know it's a hemorrhage, we're not going to give them a clot buster. If it's hemorrhage, if it's not hemorrhage, if it's thrombolytic or embolytic blood clotting and blockage ischemia, then we're going to give them we're going to want to give them a
Clot buster.
freaking the clot buster. Thank you. Okay.
So if it were a hemorrhage, the clot buster would just make the bleeding worse, right?
Exactly. Why?
Does that thin out the blood?
Yeah, it breaks up a clot.
Okay.
If you have
It
hemorrhaging,
prevents the platelets from working the way they should. So they break down the clotted blood, and obviously it will not allow the blood to clot.
Right. And then you've just got blood spilling over the brain.
Yep, they just bleed to death. They'll just bleed to death out their brain. That's exactly what happens.
Oh, man.
That's why you want to be really careful. You know what you're giving them.
If you are hemorrhaging, then how would you treat that?
If they are hemorrhaging, then remember how they drill a hole in your head?
Mm-hmm.
They may remove a piece of the skull, allow that to hemorrhage, like give you blood transfusions and clotting factors to clot, and then they'll cut a piece of bone out of your head and let it, and then that way they'll let that thing reduce. It'll let that blood out.
The first thing they'll do is to go in there and close up that bleed.
Depending on where it's at, that's true. But we're talking about the brain,
depending
right?
on where it's at, right?
Yeah, this is in the brain. So we probably don't have all kinds of treatment in the brain to stop a bleed.
Yeah.
So we're relying upon the system, the body's natural defenses to stop that bleeding. And then when that fails, we have to do something else.
Okay.
I saw a patient at the hospital the other day in the elevator that had like a helmet on, and from what I could overhear, it sounded like maybe this is exactly what happened to him, that he had a hemorrhage and they had to go and cut off a piece of his skull so that his brain could
Drain off. Let it drain off.
Yeah.
Because remember, the number one thing with the brain is there's no place for swelling and fluid to go.
Yeah.
The brain is packed inside that skull. There's nowhere for it to go. So the alternative is to bust the bone out and let it drain off, or to let it swell.
And what were the two things that they said they do with the flap, with the bone flap?
They'll cut an incision in the stomach, or excuse me, in the abdomen. They'll place it in there and sew it in there. Or the other one is they put it in some kind of solution that keeps it from going bad, from drying out and dying.
Right.
Because the bone itself is a living organism. It's living as well.
Yeah, it needs to continue to have blood flow.
Yeah.
And I think Megan was saying that there was one person that actually had a piece of their skull in their abdomen for a year.
Yeah, they'll leave it in as long as they need to.
So yeah, you want it alive, so you don't want to freeze it. And unless you're gonna put it right back on, you want to keep it somewhere where it's gonna get blood flow.
Yep, that's the docs to do all that.
Well, they do actually freeze it. Also, they can do. Yeah, I know. In the operating room where I work, we have two big bone freezers that we have quite a bit of bone flaps in.
Wow.
That's okay. You know what, Tanner? You're the man. I don't know if I could do that.
No,
I
I'm
learn
not.
something new every day.
Yeah, I'm not sure I could be down with that. Okay, moving along, guys. We're gonna move along into spinal cord injuries. Okay, unit 8 or number 8, topic 8 of the slides of the notes. Okay, we're gonna hit this hard and fast. Let me stop this piece of crap and put the next slide up, even though it's a pain in the butt. Okay, here we go. Okay, and we're back. Okay, so spinal cord injuries. The pathology of spinal cord injuries is trauma, tumors on the spinal cord, concussion, contusion, compression, tearing, and ischemia. Those are the major things that can hurt the spinal cord. So now we've moved out of the brain itself, past the midbrain, and now we're down to where the vertebral column is. Okay, trauma is pretty straightforward. That's like a car wreck. You get hit, take an impact to your back, to your spinal column, and you can have trauma that could potentially disrupt the spinal cord.
Or a fall, for example. People who are climbing.
Yep, a fall is another good example of trauma, direct trauma to the back. Okay, tumors. What's going on with tumors?
They're obviously can press on the nerves and prevent the signals from going through.
Yep. Just tumors. Yep. We develop a tumor on or around the spinal cord. It's going to diminish function, and that tumor can ultimately end up invading and innervating where the spinal cord's at. The more and more that happens, the more it's going to want to occlude and push that nerve out of the way, and it's going to compress and cause paralysis.
Yeah.
Okay. What about concussion? Can the spinal cord get a concussion?
Yeah, right.
Anything that can happen to the brain can happen to the spinal cord because it's the same kind of tissue. Okay, so concussion was characterized by it reduced itself. It was temporary, right? You had a loss of consciousness, right? But there was no other impact. You just took an impact, you lost consciousness, and it reduced itself. People wake up from it, and they're okay. You still want to get treatment, but most of the time it's not long-term. It's just an acute thing. It happens. They move on, and they heal, and no problem. Okay, but what about a contusion? What's going on with a contusion? Addison, are you can talk? Addison, she can't talk. Hello. So, Adriana, what's going on with contusion?
So contusion is sort of like bruising, right? So you injured it, and there's probably swelling, and you're gonna have possibly temporary lack of can't even think of the words right now. Sorry, I had a very long day today.
No, you're okay.
You're okay.
But yeah, it's there's gonna be bruising and swelling in a contusion.
That's it. You hit on it.
Good
So
result.
we have an impact on a spinal column, right? It causes there to be a break in blood vessels, which releases blood into that space. If we're releasing blood, we're probably releasing histamine and other inflammation type hormones and secretions. And those things recruit more fluid there to deal with the damage, right? To deal with the impact damage. As that happens, the contusion develops a compression force on the spinal cord, which can cause paralysis. Okay. Do contusions reduce themselves?
They usually will. It's like the sharp.
Yep, they usually will reduce themselves. Okay, they're more serious than a concussion because there's actually blood damage, blood vessel damage in that region. But a lot of times they'll reduce themselves. It'll just be painful as hell for whoever has it done to their back.
Yep.
Oh.
There's gonna be a lot of pain associated with the contusion on their back. Okay, what about tearing forces?
Hey, real quick, Chris. I'm trying to be on the correct page in the notes. Like, what page are we on in the notes?
We are on. Hold on. Give me 1 second. We're on page number 9.
Okay. Okay. Sorry. Go ahead.
We are on page number 9. And let's see here. At page number 9. Where the heck are we? Yeah, page number 9 is spinal cord injuries, or SCI. Okay, let's keep going.
Okay. Yeah. Go ahead.
Okay, compression forces, tearing forces. What's going on with tearing forces?
I feel like I talk too much, so I always try to wait and see if anybody else wants to answer.
Addison's at work, so she might not be able to talk. And then Ashley's got hers muted because her children, and she doesn't want to disrupt the group. And Tanner
leaves it up to me.
Just crazy. I don't know what's wrong with Tanner.
Tanner, you're awesome. Just keep going.
I'm just I can't see here where it's talking about tearing.
So we're right at the very top under pathology. It says trauma, tumors, concussion, contusion, compression. The very first
tearing.
paragraph.
Okay. Tearing.
Yep. Well, let me ask you a question. When you tear a piece of paper apart, what do you do?
You actually have like breakage of.
Yeah, you're pulling it in 2 different directions.
Okay, yeah.
Like that's what's going on. So tearing force is where you're applying 2 different forces on the spinal column, and they're going in different directions. Tearing forces can also be called shearing forces.
Okay.
Okay. You shear it like so.
You have your spinal column, even in the way it should be, with the hole in the middle, right? With
Yes.
your spinal cord, and then in an injury where you have two of those bones move in opposite directions, they're going to tear. And it might not be the entire spinal cord that gets torn, but there's going to be a lot of damage to axons in that area.
The other way that this can happen too is that if there's actual twisting forces.
So
if two vertebrae are being twisted, they're being turned in opposite directions. That is also applying a shearing force on the spinal cord. It's twisting it, and that can sever and tear those nerves.
Okay.
Okay. So basically, it's applying two different forces at any vertebrae in the spinal column, and it causes there to be tearing at the spinal cord.
Okay.
Okay. What's ischemia? What's an ischemic injury to the spinal cord?
I mean, it's a reduction in blood flow, right?
Yeah, it's a lack of blood flow. So normally we think of ischemia to the actual brain as a stroke, right? Well, what happens if at level T4, thoracic 4 vertebrae, I lose blood supply to my spinal cord at that level for some reason, right? I lose that blood supply. What's going to happen to that spinal junction?
Well, that's gonna affect where the nerves leave the spinal cord, right? And
yeah, they're not getting any oxygen anymore. Anytime any cell in the body doesn't get oxygen, what happens to it?
Yeah, everything below where that damage is happening is gonna be affected.
Well, yeah, at the level that the loss of blood flow happens, you're gonna get this really, really strange word called necrosis.
Yeah.
As those cells are deprived of oxygen, they are going to start to die.
Yeah.
And that's what ischemic injury is. We're denying that level blood. So at T4, if that's cut off from blood, those cells will start to die. Well, it's a spinal cord. It's like a power line. If the power line between your house and the house next to yours is cut right there, anybody downstream on the power line is going to also lose power.
Right.
Okay. And the last comment is with or without vertebrae. So the vertebrae do not have to be involved for there to be damage to the spinal cord itself. We can have injuries that damage the spinal cord that do not damage the vertebrae. A good one is tumors. A lot of times the tumors will innervate in between the bone and go right in and hit the nerve tissue because it's softer and it's easier for cancers and stuff to innervate. Bone is extremely difficult for tumors to invade. That hard, compact bone of the vertebrae is extremely hard for tumors to invade. Okay, most common sites where injuries can occur: C1 to C2, C4 to C7, and T12 to L2. Those are the most common sites of spinal cord injury.
Right.
Okay, moving right along. Okay.
Do you have the differences on paraplegic, quadriplegic?
I do, and they're coming up right now.
Awesome.
They're coming up right as you said that. Okay, everyone look and give me 1 second. And voila, there it is. Can you see it now? Okay, so spinal cord injury, signs and symptoms will depend on the location of the damage. So a cervical spinal injury is happening. If it says it's a cervical spine injury, where is that injury going to be at in the spinal cord?
In the cervical area.
Yeah, C1 to C7. That's where it's going to be at.
C1
okay,
to C7.
Any injuries at C1 to C7 are going to do what to the human body?
Quadriplegics.
Yep, both arms and legs are going to be impinged upon, and we're going to see paralysis in arms and legs or quadriplegia. Okay. Anything at the thoracic region, so T1 to T2 to T7, is going to cause what kind of injury pattern?
Paraplegia.
And that only includes the legs. Paraplegia only includes the legs. And then the mechanical ventilation note over on the right side says that C1 and C1 to C3, if we have damage to the spinal cord at that level, we are required to give mechanical ventilation. Adriana, I know you know the answer, so I'm going to ask you not to answer this.
Okay.
So one of the other players in the game, can you guys tell us why mechanical ventilation is required there? Everyone's muted. Okay, so you have to answer it, Adriana.
It's the nerve that.
Oh, Ashley just unmuted. Ashley, go ahead and answer.
Is it because it's like what holds up their head basically, so they can't?
There
know.
is one special cranial nerve that passes very, very close to the spinal column through C1 through C3, and it controls respiration and heart and blood pressure and heart rate. Remember the name of that cranial
diaphragm.
nerve? The diaphragm, yeah.
If there is damage in that area, that nerve doesn't work, so your diaphragm doesn't work, and you can't breathe. So you have to be ventilated in order to stay alive.
I'll help you out a little bit. It's cranial nerve number 10. Do you know the name of cranial nerve number 10?
I can't remember. That was 6 months ago.
Okay, cranial nerve number 10 is a crazy city where people go to gamble and get prostitutes south of Salt Lake.
Vegas.
I was thinking the vagus nerve, but
the vagus nerve is what does that. So it's C1 to C3. If we have damage to the spinal cord there, we have to ventilate because that's where that breathing drive comes through. And if that gets damaged, they will not be able to breathe on their own.
Okay.
So think Christopher Reeves, man. Christopher Reeves was on like original Superman was on a respirator after he broke his neck because he broke his neck at C2.
I'm sorry to go against you, but it's actually the phrenic nerve.
Is it phrenic?
The phrenic nerve is the one that innervates the diaphragm, and it goes through the spinal, the cervical area between C3 and C5.
Okay.
Yeah, I couldn't remember the name of it. I actually cheating.
You know what? I'm tired. I'm getting tired too.
Yeah. Vegas does a heck of a lot of stuff.
Yeah, and it does go through that area.
The diaphragm.
Weren't they saying that was like the gag reflex nerve?
Yes. Yep, phrenic nerve.
No, the vagus.
The vagus, yeah, vagus.
Have we beat the crap out of this?
Yeah, I think
we're ready to move on. Okay, spinal shock. Here we go. Spinal shock. Yay. Spinal shock's my favorite. No, it's not my favorite. Okay, ready, set, spinal shock. Here we go. Okay, so spinal shock right here. So spinal shock is a temporary loss of somatic and autonomic reflexes below the injury site. Okay, it's temporary. Its duration is from 1 to 3 weeks, but may be for as long as 3 months. Okay, the injury resolves itself because it's shock-based. It resolves itself, and then hyperreflexia can last up to 1 year. Okay, so they're going to have inappropriate reflex responses because it's damaged. It's hit those reflex centers, but it will resolve itself over time. Okay.
Okay.
That's it. That's what spinal shock is. It's pretty straightforward. That's all it is.
Does that just come from like a injury? Spinal shock?
Yeah. So for example, using a good example, have you ever had like the wind knocked out of you? Like you've taken a fall and had the wind knocked out of you, it's hard to breathe.
Yeah.
That's a situation where you could have spinal shock associated with that. All you've had happen is you've taken a good sharp impact and it causes your sensory system to be overloaded, right? You basically like shaking your spinal cord, really give it one good shake, right? So you don't have permanent damage, but you'll have loss of sensation in like your hands and feet, and you'll have a hard time feeling and getting sensory input from the environment. And all it is this, that you got shocked. Like, have you ever had like a bright light flashed in your eye?
Mm-hmm.
You have a bright light flashed in your eye. What happens to your vision?
For a few seconds.
Yeah, you can't really see, right? You've shocked your eyes. You've shocked the receptors in your eyes. The spinal cord is no different. You've done something to it to overload the sensory system. And when you do that, it takes a while for it to recover, just like your eyes and ears when they hear a loud sound or a bright light. You've overloaded them, and then those need some time to recover back to normal. And sometimes they don't recover as quickly, depending on the kind of light or the kinds of sound or how loud it is. It takes a while for it to recover. And the spine is no different. You take a good fall, you might lose some sensory inputs for a while, and then over time it'll heal itself, and you'll get that feeling back. Okay, moving along. Let's see here. Spinal shock we got through. Okay. Okay, I'm not going to click the slides of this. I'm just going to tell you. So compressed cord and transected cord. Under spinal cord injuries, there's two types. What's the worst one?
Transected.
Why is transected worse than compressed?
Because you cut the axons.
You have physically severed the axons, and as we know, our current medical science does not allow us to repair those. Once they're cut, they're cut. So again, think of the down power line. If a power line gets cut in your neighborhood, you are without power. But if you get too much like snow on a power line, you may get a diminished amount of power coming through the line because it's flexed and it's stretched, but you don't lose all the power going through there. Okay? That's the difference between compressed cord and transected cord. Are there any questions on those ones?
Nope, that sounds good.
Yeah, those are pretty straightforward. These ones are pretty easy. Okay, incomplete spinal injury and complete spinal injury. We're going to hit these and we'll be just about done for the night, okay? I know it's getting late. It's getting late for me too, so let's hit these two and then be done for the night. Okay, here we go. Incomplete spinal injury and complete spinal injury. So looking at just the names of those, what's complete spinal injury going to be, Ashley?
Probably means like you can't move your whole body.
Yeah, so here's the deal. So there are two parts to our nervous system. There is the sensory part that receives stimulus from the environment, and there's the motor part that initiates a motor action appropriate to that stimulus, right? Okay. Complete spinal injury means that both sensory and motor are lost. They're both gone, and it's a complete injury. An incomplete injury means that you may still have movement of a particular, like, for example, your arm, but you may not have feeling in that arm. So depending on the kind of nerve damage that you get, you may lose feeling but still have movement, or vice versa. You may see a patient who still has feeling in their arm, but they've lost the ability to move that arm.
Okay.
That's pretty much the basic big issue with this. Okay. The only thing I want to add is involuntary anal reflex or sphincter or anal wink.
Yeah.
That's for everybody in the study group. If I get to say anal wink in a study group with poo poo, I'm like the happiest person in the world.
All right.
Okay. So if they have an
Everybody
intact,
knows what the anal wink is.
if they have an intact involuntary anal reflex, it means that if that part of their body is stimulated, it means that they're still getting sensory and motor function to that. That means that they're getting motor action and nerve action through the entire spinal column. Because
So
the brain couldn't talk to your asshole if there wasn't nerves working down there.
Right.
And so that's a good sign of recovery. If that is ever lost in a patient, that is a significant diagnosis. That means they have significant spinal cord damage.
Not a good prognosis.
That is not a appropriate dog. But we're not. Yeah, if you're without your anal wink, you got some issues.
You have to wear diapers.
You're gonna be wearing diapers. Yep, and you're gonna be having some issues with that. You're gonna be carrying a colostomy bag around for the rest of your life.
Yeah.
Okay, are we good? Anybody have any questions?
Nope.
Hey, one quick thing. Tomorrow at 1 o'clock, I have to go and officiate at a military funeral at 11 o'clock. I may still make it to the library at 1 o'clock, but I'm recommending that we don't change the time. I'm recommending that if you guys get there, start studying, and I'll be there as quick as I can.
You know, I won't be there tomorrow. I'm sorry. I'm going to miss it, but
Okay, that's fine.
yeah.
So is anybody on board for tomorrow's study group at the library?
No, I'll be at work.
Okay, Alex has got to work. Tanner?
I'm up in Perry right now. I won't be there either.
That's fine. Addison? I don't think Addison works. I just think she's working right now and she'll be tired. But I'll talk to her later.
Well,
Okay,
you
we
send
good?
out your invites because there's always people who are not on right now who might still
Yeah,
be.
I'm gonna send in an email or a text message letting everybody know that again. It's Veterans Day this week, and there's been a lot of requests for military funerals and flag ceremonies and stuff. And so my unit, even though I'm retiring, they said, "Hey man, can you help us out?" And I'm like, "Yeah, I can help us out." Besides, this is the cool stuff in the Army. When you get to go like be cool and help people out, it's really cool. It's not going and living in the dirt and eating crap.
Right.
This is the
That
cool part.
fellowship, right? The fellowship.
This is taking care of your battle buddies, right?
Right.
Exactly.
Okay. Anybody got any questions, comment, concerns before we take off?
No, just one comment. You're awesome. Thank you so much for
Thank
doing
you.
this.
I appreciate the awesomeness, but we're a team.
I
We're all
second
helping
that.
each other. Okay, we're good.
Keeping us in line.
I'm definitely whipping the train. I'm stoking the fire to keep the desire up so we can all finish strong and do awesome.
Good job.
Okay. Have a good night, guys.
Thanks,
Good night,
guys.
everyone.
Ashley, give your kids a hug.
Okay.
Okay, have a
Thanks.
good night, guys.
Good night.
Okay, bye.